Hello, and welcome again to another episode of Matters of the Heart, brought to you by Haverhill Community Television and Pawtucket Medical Associates Cardiology. I'm Dr. Seth Belazarian, a clinical and interventional cardiologist with Pawtucket Medical, and I'm here again with my associate, Dr. Sunny Srivastava. We're here to talk this week about a pretty interesting topic that gets a lot of interest every now and again, but it's a topic that I think is very important for athletes and parents of athletes. So, Dr. Srivastava, tell us what we're going to review today.
Yeah, so thank you. We're going to talk about what we refer to as sudden cardiac death in the athlete. This is what we hear about, unfortunately, every now and then in the news, where a young high school athlete just drops suddenly or dies suddenly during participation in sports. And although it is rare, there are very few things that are, as universally mourned as the death of a young athlete in the community. So it becomes a big deal, even though it's a rare event. It affects, fellow students, families, institutions, communities, and so there is an interest in I guess a duty on our part to try in some way, shape, or form to screen and to hopefully prevent these events from happening.
So when you say screen, you mean, can we identify a person who's at higher risk and maybe say, you shouldn't participate, and say
right.
to other people, your risk is very low and it's safe to participate? Is that sort of what
right.
you mean by screening?
Yeah. That's exactly what I mean by screening. And so what I wanted to talk about today was, number one, some of the causes of this phenomenon in young athletes, and number two, talk about screening. I think all of us who've played sports can remember going to a physical before participating in sports, and what I wanted to talk about a little bit is what that entails, what type of things we're looking for, and what some of the guidelines and recommendations are from the American Heart Association, and what some new research is suggesting should be done or could be done as well.
Okay, great. Well, let's get right into it.
Sure. I mean, I guess the one easy way to start talking about it is to talk about how frequent are we talking here. And it's a rare entity, no doubt about it. But I guess I would state that the public health relevance is not always linked to the high rate of occurrence. There's a profound social impact here. And so in the United States, this event takes place on average in the young between the age of 12 and 24, has an incidence, I should say, of 1 in 100,000. So that's not a lot.
Uh-huh.
And another place where they studied this quite a bit is Italy. Italy has been one of the leaders in research on sudden cardiac death in athletes and screening and such. And their incidence is quoted a little bit higher at 3 in 100,000, but their studies are inclusive of older populations, age 12 to 35. So that's important because as we get older, we are at risk for other types of things that aren't necessarily high risk for the young. Things such as just run-of-the-mill conventional coronary artery disease, for example.
So a heart attack.
Yeah, right, exactly. So at the age of 35 and onward, that actually becomes the number one cause of I'll just refer to this often in the discussion, sudden cardiac death. Above the age of 35, by far the most common cause is heart attack.
Okay, so sudden cardiac death, just to make sure that I'm understanding what you're using as a term, means just someone who dies suddenly, of course, the term sudden, but the presumed cause of the death after examination, maybe after an autopsy even, is that the death was caused from a heart cause, not from some other cause, from drug use or something else. So that's what you mean when you say sudden cardiac death.
Absolutely.
Okay, and a person, of course, who has no other heart history.
All right, that's the unfortunate part of this, or the sad part of this, is that unfortunately, this sudden death is often the first manifestation of an underlying disease, because many of these things are A, difficult to pick up upon, or B, just haven't been screened for, and so that is the unfortunate reality of it, that this is often the first manifestation of the underlying disorder.
Okay. One of the things that, as you were talking, and I said to myself, 1 in 100,000 or 3 in 100,000 if you use the Italian data, that seems pretty high, because I was thinking, how many athletes are there, say, in the Merrimack Valley, if we assume the cities from Lowell to Newburyport?
Right.
There's probably that many, or close to it, and if not in eastern Massachusetts, there's several 100,000. So I just don't think that, as you said at the beginning of this, it's such a highly publicized event when it happens.
Right.
Does it happen? Does it happen a dozen times in eastern Massachusetts?
That might be a little bit high in the numbers, but I guess I can certainly just anecdotally think back over the past several years. couple times per year hearing something locally, and there's been things within the past year certainly that have happened locally that that I've heard about. Okay. Across the country, there are, I think, somewhere between 5 and 6 million competitive athletes, the majority of which are high school. Okay. You get into college, there's in the hundreds of thousands, and then there's professional, which is much fewer, obviously. So if you did the math, that becomes less infrequent than when you first think when you say 1 in 100,000, just as you suggested. Okay, very good. So, obviously we got to know what causes this sudden cardiac death. Yeah, so we talked about those over the age of 35 and coronary artery disease, heart attacks. That's the most common cause. But I want to focus in on the young, certainly. That's what we're here to talk about today. And the most common cause by far in the young is a condition called hypertrophic cardiomyopathy. More than a third of sudden cardiac deaths in the young or in the athletes is due to hypertrophic cardiomyopathy. There's numerous well-known athletes who've died from this. One that sticks out for me from years ago was Hank Gathers, a college basketball player who collapsed at the free throw line, rather dramatically, obviously, but he went on to be discovered to have hypertrophic cardiomyopathy. He died and discovered to have hypertrophic cardiomyopathy. Locally, Reggie Lewis from the Boston Celtics in 1993 passed away during athletic competition, and it's thought that he had hypertrophic cardiomyopathy as well. So it's a very prominent, that's the wrong way to say it, it's the most common cause of sudden cardiac death. So let's just break that down, though. Hypertrophic cardiomyopathy. Yep. So just to explain the term, it sounds fancy, but... Yep. So, let me break it down. So cardio refers to the heart. Myopathy refers to a disorder of the muscle, the heart muscle, so cardiomyopathy. And the hypertrophic refers to a thickening or overgrowth of some of that heart wall muscle. And usually it's one particular wall versus another wall. Those details are probably beyond the scope of this discussion. It is largely considered to be a genetic disorder. And actually, its incidence is not insignificant. It's quoted as being about 1 in 500, 1 in 600 in that range. So that's pretty common. It has various degrees of its manifestation as far as how severe or not severe it can be. And it's often considered to be or not often, it is considered to be a genetic disorder of the contractile proteins that make up your muscle. And so a couple things can happen. One, that because of that thickening of the muscle and the disarray of the cells that make it up, you become prone to what we refer to as ventricular arrhythmias, fast, dangerous heart rhythms coming from the heart, where all of a sudden the heart can just take off very fast, and it's a life-threatening heart rhythm problem, which we've actually talked about previously in this forum. But also people can have passing out episodes when they're exerting themselves. This thickness of the wall can sometimes obstruct blood flow coming out of the heart. And so when you're exerting yourself physically, and your body can't get what it needs from the heart as far as blood and oxygen goes. Okay, so let me make sure I get that right. So hypertrophic cardiomyopathy is an excessive thickening from a genetic reason, just born with it, just not something the person did, but they were born with it. Yeah. The heart thickens, so that muscle is diseased because it's excessively thick, and that thickening predisposes them to irregular heart rhythms. Yeah. Okay, so this thickening really is something that you can pick up. Yeah, so it's... That's a tricky question. You can often not pick it up by just sitting down, chatting with somebody and listening to their heart. There is often a murmur associated with this, what we refer to as outflow tract obstruction, where the blood can't get out of the heart as well because this muscle's thickened so much. So there is a characteristic murmur you can hear from that. But not everybody has that murmur. Not everybody has it to that degree. So by a conventional sitting down and chatting with someone, doing a history and physical exam, you cannot always pick it up, without a doubt. And family history obviously becomes very important. We always spend a great deal of time looking at one's family history. If there's a family history of sudden cardiac death or cardiomyopathies in the family, that's important as well. A few more words about hypertrophic cardiomyopathy is that this condition is such that inevitably we restrict folks from taking part in competitive physical sports as a result of the higher risk of sudden death with exertion. Okay. So that's the most common cause. Tell us about. So that's about so the actual percentage that's quoted is 36% of them are due to that. The next most common cause is something that we refer to as anomalous coronary arteries. So that's about 19 to 20% of all causes. of all cases. And what that is, to break it down, is our hearts have coronary arteries that deliver oxygen-rich blood to feed the muscle of our heart. And there's a normal anatomy. And in some individuals, at birth, they have a congenital defect where the arteries don't go where they usually should go. And some of these end up being a problem. Depending on where the arteries course, they can sometimes compress or become compressed, and that can lead to a sudden and fatal heart attack as well. And this is something that's very difficult to screen for. Usually the first manifestation of it is sudden death. It is not something that's picked up in just talking with somebody. It's not picked up upon on an EKG usually. But what is interesting, I think the majority of folks who do ultimately pass away from this, in the weeks prior to it, the majority of them have some what we refer to as exertional syncope, passing out when you're exerting yourself, or becoming extremely lightheaded when you're exerting yourself. So that's a very important symptom that one should not blow off. Passing out at peak exertion is a worrisome thing that we'd like to know about, certainly.
Okay. So that's called anomalous coronary arteries. Mm-hmm. So the first thing you said was hypertrophic cardiomyopathy. That's the biggest cause where the heart is thickened. The second thing is the arteries or the plumbing is not as designed in the master plan.
And there are actually quite a few benign anomalies. So your artery doesn't course the way the majority of folks do, but no big deal. That's fine. But there are certain anomalies that are actually the problem, which is beyond the scope of this discussion, certainly.
In a basketball player named Pete Maravich, I think, is the example of this one, right? He had, instead of two arteries on one side and one on the other side, all three came from one location, I think was his.
Right. And he did well for a long time, obviously, and then boom, all of a sudden. So, so those are the two, by far, but the two of those combined make up more than half of all these cases. And then we start getting to a lot more rare or infrequent things. One that I think bears mentioning is something called, I'll just say the fancy name here, arrhythmogenic RV dysplasia, or ARVD is referred to it. And this is a condition that, again, is genetic, and in fact is actually much more common in northern Italy for whatever reason. And as a result has been studied quite extensively by the Italians. But what happens is the heart's made up of multiple chambers. And this one particular chamber, the right ventricle, for whatever reason, the genetics are such that the muscle is infiltrated by or replaced by a fatty type of tissue. And this, in turn, then predisposes you, again, to these life-threatening heart rhythm problems. And that's the cause of death, again. This ventricular tachyarrhythmias are just a bad heart rhythm problem.
So you said fat grows in there. Is that because these people are fat, or what are you saying by that?
No, sorry. So absolutely not. No, it's fatty tissue that infiltrates in there, but it's mediated by some genetic disorder.
Okay, so again, something just genetic that these people didn't do.
You didn't do anything to do it. It's you can blame your parents, I suppose, but it's genetic. And again, it is not so common here as a cause of sudden cardiac death. Interestingly, as I think I mentioned, in northern Italy, it is very common compared to here. 10 to 12% of their sudden cardiac deaths are from ARVD. And for whatever reason, obviously I think genetics at play here, the Veneto region of Italy it's very prominent. And so I think that's a large reason why the majority of the research in this comes out of Italy.
Okay, great. So we have three causes that account for most of these reasons. Any other causes that you'd like to mention before we talk about some screening strategies?
Yeah, so there's certainly other ones. There's something that's rare, but it's called the long QT syndrome, and it's a certain abnormality on the EKG where it can also predispose you to certain types of heart rhythm problems. It's probably not worth going into too much detail on that. There's something called Marfan's syndrome, which is also a genetic condition where the body, or I should say the aorta in the body, the main artery of the body, is prone to stretching and dilating, and can also rupture at an unpredictable time if you don't know about the diagnosis, and that can be a cause of sudden death as well. Think of an athlete, there's a lot of people who have had this, but from an athletic standpoint, I think the one more well-known one is Flo Hyman, an Olympic volleyball player. I think more recently, some well-known cases was, didn't John Ritter just pass away from this as well?
But I think that's an example, just to help clarify, that aneurysms can cause death. An aneurysm can be anywhere. They can be in brain arteries, arteries of the chest, arteries of the abdomen. People have heard about aneurysms rupturing and causing death.
Right.
We often think of it as something that causes death in older people because the artery degenerates from that usual plaquing process, atherosclerosis. But you're talking more about young people whose walls of the artery don't have a disease. They're just genetically not right.
Yeah, so this condition is, it's a, to get really sciencey on, it's the fibrillin gene, and it is involved with, it helps make normal blood vessel walls. And disruption of that then renders this blood vessel prone to stretching and dilating and ultimately rupturing as a result of those increased forces. So it's not, again, not a common cause of sudden cardiac death, but not insignificant either by any means. I think one that actually bears a few moments of discussion, because I think it is not uncommon and becoming more well recognized, something referred to as commotio cordis. This is a condition that someone dies suddenly as a result of a relatively innocent, blunt chest wall trauma. A projectile, so a baseball to the chest, hockey puck to the chest, lacrosse ball to the chest. And what happens is this projectile needs to strike one's chest with a certain degree of force or certain velocity or speed, not too fast but not too slow, a certain location, and also at an exact certain time within your cardiac cycle.
So a whole bunch of probabilities adding up to a heap of bad luck.
So each and every one of those things are rare, and then you put them all together, it's exactly what it is. Very bad luck that it hit you in the wrong place at the wrong time with the wrong amount of speed. And what happens is this particular part in the cardiac cycle, if you deliver this force there, energy there, it also triggers a life-threatening ventricular heart rhythm problem. And so we hear about this all the time, and it's most common in the sports with projectiles, so baseball, softball, lacrosse, hockey. It can occur, though, in other things. There's been examples of it in karate, chest wall trauma, boxing, horsing around with the kids, innocent things as well. And it has led to, in many communities, defibrillators, automated external defibrillators, being present at sporting events. And I don't know which town has which, but many, I think, local towns do have defibrillators now at sporting events, largely for this reason. But also it would treat other events as well. And so there's a lot of work being done to try to minimize this, of course, work being done to look at safer baseball, safer softballs, better chest wall protection for catchers, etc. So it bears mentioning. Certainly.
Okay. Well, that's a fantastic review of the causes. I'm very excited to hear about what should we be doing, what should I be doing when someone asks me about screening for pre-athletic participation, or if a parent is concerned about their child for some reason, what should they be looking for?
So with regards to screening, there's a lot of disagreement, actually, on what should be done from all these different professional societies. In this country, in 1985, 1994, and again in 2005, the major heart societies have met, that being the American Heart Association, the American College of Cardiology. They have met to set guidelines, to give practitioners like you and me ideas of what we should be doing when we see young people, screening them, in pre-participation screening, we refer to it as. And it's tricky because screening tests are, first of all, not meant to be diagnostic tests. They are meant to cast a large net, so to speak, and you'll certainly capture a lot of what we refer to as false positives, and that's the nature of a screening test. And you have to keep in mind that what the prevalence is, or the incidence, and it is a rare event, nevertheless. So the current customary practice, unfortunately, is that there's no real universally accepted standard among all the different states. Interestingly, 10 or 11 states don't even have a standardized form for one to follow. Some forms are very specific and detailed. Others merely just require a doctor's signature to say, yeah, Johnny's okay to go play sports. In some states, chiropractors can do it. Other states, NPs or PAs, so nurse practitioners or physician's assistants, can do it without a physician being involved. So there's a lot of variability and lack of any sort of universally accepted standard in this. And what the current recommendation is from the American Heart Association is, and I'm going to quote them, actually, I wrote it down here, just this is what their statement is that, quote, some form of pre-participation cardiovascular screening for high school and collegiate athletes is justifiable and compelling based on ethical, legal, and medical grounds. They go on to say, in quote, non-invasive testing, and I'll talk about what that is later, can enhance the diagnostic power of the standard history and physical. However, it is not prudent to recommend routine use of such tests such as electrocardiogram, echocardiography, or stress testing.
What does that mean?
So, right. So they say, yes, we should evaluate people. And what they recommend is to sit down and talk with someone, take a very thorough history from them. Have they had chest pain when they exert themselves, lightheadedness when they exert themselves, dizziness, passing out when they exert themselves. Equally as important, or if not more important, is a very detailed family history. That's where you really start asking about people in the family or extended family who've died suddenly, unexpectedly at a young age. Those are often some tip-offs that there could be something running in the family. And then a physical exam. From our standpoint, focusing on the heart, obviously looking for certain types of characteristic murmurs. And that's what the American Heart Association recommends. They have felt that because of the large amount of people that need to be screened, we're talking millions here, that the routine use of something such as an electrocardiogram or more potent testing such as an echocardiogram is not necessarily beneficial given the low incidence. Now, there have been other studies or other agencies or groups who disagree with that notion, and I specifically would talk about the Italians. They recently, within the past month or so, published a pretty interesting analysis about their experience. And things are a little different in Italy, certainly with the type of healthcare system they have and with regards to who is doing athletic screening or pre-participation screening there. In Italy, this is done specifically and solely by sports medicine specialists who have had 4 years of postgraduate training in cardiology and sports medicine. So very highly specialized individuals. And what they did, or what they published an analysis of, is from the year 1979 to 2004, so 26 years or so. They routinely performed a standard EKG on all athletes getting ready to participate in competitive and this is, I believe, high school and college level. I can't remember exactly which level, but it was over 30 to 35,000 athletes that were screened. And what they found that of those, about 9% were ultimately referred on for additional testing because there was something abnormal. And of those, over 600 ultimately were disqualified from participating in sports because of the findings that were discovered. And I think what's interesting to focus in on is the condition of hypertrophic cardiomyopathy, because this is invariably the most common cause of sudden cardiac death. And 82% of those folks had an EKG abnormality, which is a pretty good number. And of interest is the fact that only 23% of those people had either a family history or a murmur, which is what is recommended as the customary way of screening for these people. So a fair amount of them would have been, quote-unquote, missed had you followed the conventional methods of screening for or pre-participation screening. And this is a very important condition to pick up on, certainly, with major interventions that